All right. Well, I think we probably should get started so we can stay on time for this afternoon. Welcome, everybody. It's my pleasure to welcome you to, believe it or not, the 4th annual Ross Debates in Ophthalmology. The Ross Debates were established in 2022 through an endowment gift from Dr. Harold Ross and Janice Ross. Their purpose is to encourage lively discourse between the participating speakers and the audience at our annual conference. And when I was speaking to Hal about the donation he wanted to give and what he wanted to support, we had a long discussion about various things, and he actually came up with this idea, which I thought was a fabulous idea. And we added this to our schedule a few years ago, and it's been an absolute hit. So no pressure on you guys today, okay? Dr. Ross was a faculty member of the Flom Eye Institute. He joined the university in 2013 after we acquired his practice in Geneva, New York, a thriving practice that's still going on today and growing. He continued practicing in Geneva until he returned to his passion teaching, becoming a staple in the resident clinic where he mentored numerous and aspiring ophthalmologists. So thanks again to Hal and Janice Ross for this. Now it's my pleasure to introduce Matt Geringer. So Matt is one of the foundational pillars of FEI. We started together here in 2003. Remember that, Matt? Where are you, Matt? That was a long time ago. We're still here. He started his career here after completing a pediatric ophthalmology fellowship in Duke in 2003. And since then, he rose from the rank of associate professor very quickly to full professor. And along the way, he started the FEI Pediatric Ophthalmology Service, served as the residency director, and conducted clinical research through PDIG, resulting in multiple publications. And he continues to do research and has become a nationally recognized expert in ophthalmic education, presenting his work all over the States on resident and fellow training. The one thing I also like to say is Matt had always participated in our childhood screening effort throughout the city, but he really committed to it these last 2 years. And since he committed to this and Matt Haney joined him, we've gone from screening a few hundred kids per year, and this year we ended up screening 3,500 children in the Rochester area this year. And when 25% of those kids fail that eye exam, it makes a big difference in their lives to get free glasses that we provide for them. So Matt, thank you and your team for that. Matt trained in medicine at the University of Michigan, did his residency training at Pitt before completing his fellowship and coming here. Please give a warm welcome to Matt Geringer.
Thanks, Dave. My Mondays and Fridays are like my best days. It's so much fun to go out to schools, and thanks for everybody's help there too. Okay, so this is like the fun part of the meeting usually. Hopefully no fists, no blood today, guys. Okay. Our first debate's going to be with Ron Plotnik and Rachel Wozniak. Ron's a clinical professor of ophthalmology and joined the University of Rochester in 1991 before it was even the Eye Institute. So foundational pillar goes there instead of here, I think. His practice includes medical management of corneal disease with specializations in dry eye and herpes virus. He completed his undergraduate training in medical school at the University of Michigan. Michigan people, yes. He did his residency in ophthalmology in Wisconsin, and there he went to do his fellowship in corneal and external disease at UC Davis, not Irvine. Thank you, Steve, for fixing that this year. Before coming to Rochester. Besides being a top-level corneal specialist, Ron has a keen interest in the operations side of ophthalmology and has earned a master's in medical management and an MBA from the Simon School. He's an essential part of our operations team and has helped the department employ lean business practices that have optimized our efficiency. Rachel is an associate professor of ophthalmology and is an integral part of our corneal service as well. She's an accomplished surgeon and is also very involved with our education mission as associate chair for education and co-director of the residency program. Thank you for that. As a clinician scientist, Rachel has an interest in developing novel therapies to treat corneal infections. Her work has resulted in multiple publications and grants, including a K Award and an R01 from the NAION and a Career Development Award from RPB. She's also patented novel treatment strategies for corneal infections. Rachel received her medical degree and a doctorate of molecular genetics from Tufts, and she came to the University of Rochester for residency and stuck around since then, doing her corneal and external disease fellowship here as a Heath Fellow. Please welcome Rachel and Ron as they present our first Ross debate of the day, serum tears versus Sinedgerman and neurotrophic keratitis.
Good afternoon. Last year, Rachel and I battled it out, and I lost in a dramatic I lost in a dramatic fashion. So I'm trying to, at least if I'm going to go down, at least, have a little respect maintained. So we're talking today about Synedrimin versus serum tears for neurotrophic keratitis. So Oxervate or Synedrimin, there are no generics, has been around for several years. It costs a lot of money out of pocket if the patient was going to sort of be hit by that out of pocket. The procedures for getting it has been kind of tough, but I don't think anyone who's used the product over time would deny that it's an extremely effective product. So we're talking about neurotrophic keratitis today. So there are epithelial defects, for instance, for other reasons, not neurotrophic keratitis, and we're really not including those in this group. So neurotrophic keratitis is a degenerative disease of the cornea epithelium resulting from impaired corneal innervation due to damage to the ophthalmic branch of the trigeminal nerve. This can lead to epithelial breakdown, poor wound healing, stromal melting, perforation, and there are a variety of reasons: infectious, herpes simplex and herpes zoster, most common, surgery involving the trigeminal nerve, systemic diseases like diabetes and MS, ocular surface diseases, contact lens, chemical burns, radiation therapy. And we've also seen it after vitrectomy in patients. There's also some congenital conditions as well. So up on the right is the normal healing when there's an epithelial defect. We have a lag or a latent phase. There's migration of the epithelium. There's a proliferative phase and there's an attachment phase. And with neurotrophic keratitis, that system is disrupted in some way, typically due to poor innervation. So this is just a picture of the epithelium. We have the stromal nerves coming in from the limbus in the anterior third of the cornea, and then coming up to the subbasal nerve plexus, and then coming up through the epithelium and into the epithelium, innervating the epithelium from below. So the nerve anatomy, the fifth cranial nerve, subbasal nerve plexus. All these things are important for maintaining the integrity and the clarity of the cornea. So these corneal nerves release neuropeptides such as substance P, calcitonin, gene-related peptide, and there's a lot of other ones that they don't directly add when you put it on the cornea, but they facilitate production of those neuropeptides, leading to appropriate epithelial cell proliferation, migration, adhesion, and differentiation. So in terms of the pathophysiology, loss of sensory input alone, in addition to the fact that those nerves facilitate production of neuropeptides, decreases epithelial integrity. The substance P and nerve growth factor are due to reduced trophic support, decreased epithelial cell mitosis, tear production, and blink reflex, and this can lead to chronic epithelial defects and stromal degradation. The classification that's typically used is the Mackey classification, and we're talking about stage 2 and stage 3 primarily. Stage 1 is superficial punctate keratopathy with early epithelial changes. Stage 2 are persistent epithelial defects without stromal involvement, and then stage 3 is stromal melting, corneal ulceration, risk of perforation, and thinning. So here we have a photograph of an eye. On the bottom is healed, and you can see to the far right there are corneal nerves present with partial healing. This is with Oxervate. We see some nerve fibers, the epithelial defect smaller versus the top, and then complete healing as we go forward. The mechanism of action is it interacts with specific nerve growth factor receptors in the anterior segment of the eye, promotes healing and nerve regeneration. It mimics endogenous nerve growth factor, NGF, to restore corneal innervation, enhances neuropeptide production, and restores the natural release of neuropeptides from corneal nerves, a key mechanism in the effect for neurotrophic keratitis. And here are two more examples of neurotrophic keratitis. The one on your left shows more stromal involvement, perhaps even some thinning. The one on the right looks more superficial. And again, we have baseline, and then with Oxervate, we have baseline up in the upper left, and then healing of the surface. And then finally, at week 8, there's opacity to the anterior stroma, but the surface is healed. And we see the fluorescein pattern for this down below with the amount of fluorescein uptake decreasing as we go on with treatment. Again, we have on the upper left a neurotrophic ulcer. And the hallmark of these neurotrophic ulcers are poor corneal sensation. I doubt anyone has a Cochet-Bonnet anesthesiometer in their practice anymore. That was that little device that put out a little wisp and probably transferring germs and viruses from patient to patient. Now we just use a Q-tip and pull the, wisp it out and touch the cornea. So it's a little bit subjective. There are more objective methods, but they're not really available. Okay, so 2 quick trials. The Reparo trial, this is sort of the standard trial for the product. It's an 8-week multi-centered randomized double-masked vehicle-controlled trial, including 156 patients with stage 2 or 3. At week 4, 58% of patients achieved corneal healing. At week 8, 74% achieved healing. For long-term follow-up, 80% of those who achieved complete healing after 8 weeks of Oxervate treatment remain disease-free after 1 year. And the other thing is if you don't achieve complete healing in the 8-week course, you can do it again. The second study at week 8, 70%, and finally long-term 65.2% with 80% total with achieving complete healing. Okay, so the Oxervate consistently demonstrated high rates of corneal healing across multiple studies. Sustained healing observed with 80% remaining disease-free, generally well tolerated. Candidates with viable corneal nerves are more likely to benefit than those with severe nerve damage, which may have reduced response. And it is kind of difficult. It has to be stored appropriately. And the amount of money the patients are paid, the patients have to pay out of pocket is typically $0, but the product itself retails for about $90,000 per episode, per 8-week course. Okay, so I'm just going to sort of go quickly to go back and forth between the benefits and the risks of Sinedromin versus autologous serum tears. For the mechanism of action, the Oxervate is recombinant human nerve growth factor, promotes corneal nerve regeneration and epithelial healing, whereas serum tears has more of the cytokines and neuropeptides that we would want, but they have to come with the tears. They're not, because they're not involving division and reproduction of nerves and growth of nerves. The Oxervate causes indirect production of these particles, which is greater than the direct from the autologous serum tears. It's a recombinant biologic versus the patient's own blood. FDA approved, yes, on the Oxervate, no on the autologous serum, but it doesn't really matter. It's well accepted as a treatment for neurotrophic keratitis. The indications for Oxervate are stage 2 or 3, and for autologous serum, 1 or 2. And then there's evidence. There's a lot of anecdotal evidence for serum tears, and these several, which I haven't even mentioned, bigger studies looking at Sinedromin. Healing rate, 70% healing by 8 weeks in clinical trials, whereas serum tears, 50 to 70% healing, depending on the severity and the duration. Healing often seen within 4 to 8 weeks. With serum tears, it can be variable. There is a small amount of relapse, 20%. For Oxervate, it's greater with serum tears. Corneal sensitivity improvement, yes. Proven corneal nerve regeneration, minimal to moderate improvement in sensitivity for serum tears. And demonstrated confocal microscopy and anesthesiometry for the Oxervate, not so with the serum tears. Dosing schedule, 6 times a day for 8 weeks. Serum tears are anywhere from 4 to, well, some people use them as much as every 2 hours. Some sort of from twice a day up to 8 times a day is pretty typical. The shelf life is at room temperature is not great for Oxervate, and even worse for serum tears. It really needs to stay frozen. There are some protocols which allow you to take a certain amount out of the freezer and refrigerate for a certain period of time, but I think the freezer to eyes is the typical. Preservative-free, both yes and yes. Adverse effects of Oxervate, just local irritation. Serum tears, same thing. People do get relief sometimes with serum tears. Systemic risk, none for really either one. Contraindications, no, not really, unless bloodborne infections and poor venous access for serum tears. Costs $96,000 for 8-week course, but a typical patient pays $0 out-of-pocket expense. In my mind, it's like getting chemotherapy. You know, they give it to you with a bill. It costs $20,000 or $30,000. You're not paying that. You may not be paying anything. So they're kind of made up numbers, especially when the patients are able to get this product. In terms of serum tears, the spread that I saw was 300 to 1,000. I think we are only at like 250 here, and you can order the tears platelet rich or platelet poor. We typically use platelet rich. There are commercial products in terms of serum tears, which I don't have any experience with. The availability of Oxervate is improving and has improved over the last 2 years. Patient compliance, challenging due to high frequency and handling logistics for the Oxervate and serum tears. People hate serum tears because it's got to stay frozen. You got to put it in your hand. You got to sterilize the scissors. You got to cut the thing open. Then you got to repeat everything at the end. But you got to kind of have a degree in chemistry to know how to use Oxervate. They come in these vials. I mean, you look like a scientist trying to do all these things. Ideal candidates for Oxervate are level 2 and 3. 1 to 2 for serum tears, used in bilateral, yes, for both. And most of this, I think I can skip just for time. And then this is just a healing chart going through Oxervate versus serum tears. So corneal nerve regeneration, yes on the Oxervate, no on the serum tears. Neuropeptide support, high with indirect, but almost none directly direct for serum tears. Epithelial cell proliferation and migration for both. Inflammation modulations. There's really not a lot of decreased inflammation that you see with Oxervate, but you do with serum tears. Tear film support, no. Antimicrobial protection, no. For Oxervate and a little bit on the serum tear side. And restoration of corneal nerve function, robust and partial. And I am going to stop. So thank you.
Okay, thank you. Thanks, Ron. And I love the Ross debates. I think this is our 4th year. We've been doing this since the start. So Ron is a long-term mentor, colleague, and friend of mine. So I appreciate you going toe-to-toe with me every year. And maybe you'll win one year. So, just keep that. Just kidding. Okay. So my job is to convince you to not think about Oxervate or Synedrimin, but think about serum tears for the treatment of neurotrophic keratitis. So fortunately, Ron did a great job at kind of introducing the disease and telling you a little bit about it. So I won't belabor this, but just to say there are many reasons or causes for neurotrophic cornea. Probably our herpetic infections are probably among the most common, but any of these or a combination of these can lead to that condition. And as he pointed out, the Mackey classification is probably the most common way we categorize or stage neurotrophic keratitis. It really can run from seeing just PEE on the surface of the cornea to profound stromal melt and perforation. So my case study, really, which kind of frames this debate, is a woman who's probably pretty common to both my clinics as well as Dr. Plotnik's, 73-year-old female, history of HSV, epithelial and stromal keratitis, numerous recurrences, and she presents with a non-healing corneal ulcer. So what do? You try preservative-free tears around the clock. You have her on ointment. You have her on a prophylactic antibiotic. Maybe you're taping the lids. Yeah, it's a little bit of steroid. You've tried the amniotic membrane, Bio-D in the office. That helped a little bit, so you tried that 5 more times. Now she's in a contact lens. You're changing that monthly, and 3 months go by, and we're not getting anywhere. So what do? Suggest a tarsorrhaphy. Patient's not interested. So now what? So for my practice, I have been using serum tears actually more and more as I as I go along in my practice. And these are the reasons why. There are many, many benefits of serum tears. They're anti-inflammatory. Okay? There's a broad set of anti-inflammatory mediators, neuropeptides, vitamins, et cetera, that promote an anti-inflammatory response in the cornea, promotes healing. There are numerous growth factors in serum. It is typically pretty low cost. Actually, most patients now, if they have some insurance coverage, they're going to be paying less than $100, and they're getting about a 6-month supply. You can tailor the dosing however you like. You can use it as frequently or as infrequently as you like. It is completely biocompatible. There's no risk of allergy. It's probably the closest thing we have to real tears that you can give patients. And of course, it's preservative free. So just to drive home the point, what this chart shows is the comparison of serum that you're going to collect from your blood draw to endogenous tears. This is not a complete list, but what it can show you is the relative concentrations of each of these different components in the serum versus in your tears. And you can see how similar actually the composition of serum is to your natural tears. The ones in yellow do show a small difference, usually on an order of 10-fold or so, either higher or lower. So you can kind of look there towards the yellow. The red there, this is the basis of synedrimin, is the red. In our regular serum tears, you can see that in our endogenous tears, the levels of natural human nerve growth factor are about the same. And these are in nanograms per mil. The dose of synedrimin is 20 micrograms per mil. That's like 10,000 times higher than what would be naturally found in your serum or your tears. So just to kind of put that into perspective. So how do you do it? Basically, patients go to the lab. They're going to get about 350 mils of their blood drawn. It's going to be centrifuged down. They're going to take the top portion of the centrifuge, which is all the plasma, and they're going to fill a giant kind of long IV tubing with that plasma. And then what the technician does is he will crimp it every couple of inches. So you get all these about couple inch kind of crimped pieces of IV tubing. Okay, and those are going to serve as the individual doses that patients will use as the tears. They do have to be stored in a freezer. And as Ron pointed out, you do need a pair of scissors to open up that tubing and use the little crimps as eye drops. And we teach the patients how to clean the scissors, to sterilize them, and to cut them, and then you can kind of use them. I usually tell patients you can travel with these. You can take them to work or even on vacation if we keep them on ice. If they get thawed, the freezer power goes out, we do tend to throw those out and get a new batch. So they do need to stay in the freezer until they're used. But patients will receive on average somewhere between 500 and 700 of those little crimps every time they get a blood draw. So they're good for months in their freezer. Okay. So what's the catch? And why isn't everybody on serum tears? I think probably one of the biggest barriers is just how easy or hard you might think they are to use, right? They're super inconvenient. They have to stay in the freezer. You need a pair of scissors. You need to sterilize the scissors, right? Sometimes you have to cut the crimp a couple times to get all the serum out. And so for some patients, that's hard to fit into their busy lives. And it's just a challenge. They're also hard to get, right? You can't go to CVS and get an order of serum tears. So, we are limited by where patients can get access to compounding pharmacies to make the serum tears. There are some commercial outlets that are trying to help improve access, but I'm not sure they're any easier to kind of work with than, for example, coming into our lab here and getting their lab drawn. So it's not widely available to everybody. And I think probably the biggest catch, or maybe where people get some hesitation around serum tears, is they are a little bit like magic. We know there's lots of things in serum. We don't really know which ones are the most important. What is really driving the healing? What do we what is the magic combination of all those components? And there are people who are studying this. Actually, I know there are people with funded grants to look at the composition of serum tears to understand that a little bit better, in hopes to try to commercialize a product, with all the most active components. Okay. So what about synedrimin? Well, it's not anti-inflammatory like serum tears. It's definitely not low cost. Can't really tailor the dosing, can't change the concentration, and you don't change how frequently you use it. Does promote healing for sure. Not biocompatible. It's not made out of your own body, so you could have some allergy, but it is preservative free. So based on my little red X's and green, I think you can see that serum tears really are the way to go. So from my perspective, serum tears really does provide the closest natural tear supplement out there. And for the appropriate patients, the benefits really can outweigh the inconveniences. I have been treating, I don't even know how many. I probably have 100 patients, on serum tears at the moment. I have never seen ocular toxicity. I've never seen any adverse events. And the beauty of it is with each patient, we ultimately end on a custom dosing regimen, and we fit it into their regular, routine of regular artificial tears and whatnot. So it's very personalized and customizable. So thank you.
Okay, we're gonna have a 1 minute rebuttal from each of you, and Steve's gonna put up some slides for some voting as you do that.
I think really that both products. I think that both products are appropriate. I think the real question comes down to, you have sort of a stage 2 or stage 3. What are you doing at that point? So for stage 1 or 2, I would agree serum tears, probably easier to get, and it has more nebulous endpoint than Oxervate. But for sort of advanced 2 into 3, my personal experience just hasn't been that serum tears is as effective as Oxervate. So I honestly, I agree with everything you said. I just put a little different emphasis on it and what the next step should be once things are progressing.
Ron's always so kind. Go get him, Rachel.
I agree. I mean, I think ultimately NK is a really difficult disease to treat. It's complicated. Every patient is different. Their comorbidities. There is really no one way to do this. And so obviously the purposes of the debate, we seem very one-sided, but there is a lot of mutual agreement. And I think that the serum tears, even in severe cases of NK, can still play a role as part of the overall therapeutic regimen. It just, if nothing else, patients always report to me how soothing their eye feels, how good they feel. I mean, it's a real positive experience for them. So I think, even just having something, okay, come on now. Oh. No, but I think having that as part of the toolkit is super important, even in severe cases. Oh, it's really close. Wait. Oh.
Okay, if you haven't gotten your phone out, get your phone out and vote and see. We could stop it at 50-50.
What?
Ron's making
okay, wait, I see people from Dompe in the audience. That's not fair.
Thank you, everybody. Rachel and I we work side by side together, and this will not go. It's going to be a thing. Okay.
This is a thing. Yeah. Okay.
I think we're going to take questions at the end of all the debates. Is that the format? Yeah. So hold your questions till the end of the debates. Okay. We are up to our second debate. We're all good? Good. Thanks, everybody. So next is going to bring together a neuro-ophthalmology team of Bayan Othman and Natalie Brossard Barbosa. Bayan joined us in 2021 as assistant professor of clinical ophthalmology. She's an experienced neuro-ophthalmologist with an intensive background in adult and pediatric disease, and thank you for taking care of all the kids. It makes my life a lot easier. She received her medical degree from Jordan University of Science and Technology in 2006 and followed with an ophthalmology residency at the King Abdullah University Hospital, receiving her certification in ophthalmology in 2012. After practicing for several years, she came to the U.S. in 2017 and completed 3 fellowships in ophthalmology and pediatric ophthalmology at Michigan State, Houston Methodist, and University of Iowa. She has extensive record of publication and research and is an editor of the American Academy of Ophthalmology's iWiki. Natalie is an assistant professor of ophthalmology who started with us in 2023. She's quickly become a vital part of our neuro-ophthalmology service. She earned her master's degree in cellular and molecular biology at the Universidad de la República in Uruguay, where she went on to receive her medical degree and do her residency training in ophthalmology. She then traveled to Toronto, where she completed 2 clinical fellowships. The first was in glaucoma and anterior segment, the second in neuro-ophthalmology and strabismus. Natalie has numerous publications in scientific and clinical journals and presented lectures at NANOS. Like our other neuro-ophthalmologists, she sees all manifestations of neuro-ophthalmic diseases and performs adult strab surgery. Please give them your kind attention as they present all angles of our patients on GLP-1 agonists at increased risk for NAION. Bayan, you're first.
Good afternoon, everyone. So thanks for inviting me to talk about this. And this is the second time for me personally to do this roast debate. I enjoyed it. I lose the first time, and we'll see what will happen this time. Okay, so our question is, are patients when GLP-1 agonists are increased risk of NAION? So let's just take a brief introduction about NAION and GLP-1 agonists. So NAION, as you know, non-arteritic anterior ischemic optic neuropathy, is the most common acute optic neuropathy in patients over 50 years of age. There is higher frequency in the Caucasian population than in Black or Hispanic individuals. So this is a typical fundus photos for a patient with NAION. Usually there is swelling of the optic nerve, but more prominent segmentally. So in this patient, there is more swelling inferiorly. And this is also a typical visual field abnormality in patients with NAION, which is altitudinal visual field defect. So GLP-1 stands for glucagon-like peptide 1, a naturally occurring hormone in the body that plays a role in regulating blood sugar and appetite. So GLP-1 receptor agonists are a class of drugs that mimic GLP-1's effects, making them effective for treating type 2 diabetes and also helping with weight loss. So why we are talking about this? Because semaglutide, a glucagon-like peptide 1 receptor agonist, has recently been implicated in cases of non-arteritic anterior ischemic optic neuropathy, raising safety concerns in the treatment of type 2 diabetes. And as you all know, NAION is untreatable disease and can cause permanent and significant severe loss of vision. So back to our question, which is, are patients on GLP-1 agonists are at increased risk of NAION? So from my side, I say yes, probably, because there are 2 large-scale studies and a case series supporting this association. So there are 2 large-scale studies conducted in Denmark found that patients using semaglutide had more than double the risk of developing NAION compared to those on other diabetes medication. So this is a study that showed that once weekly semaglutide doubles the 5-year risk of NAION in a Danish cohort of more than 400,000 persons with type 2 diabetes. So the conclusion from the study was that during 5 years of observation of all persons with type 2 diabetes in Denmark, use of once weekly semaglutide independently more than doubled the risk of NAION. Given the irreversible nature of NAION, it is important to acknowledge this risk, and upcoming studies should aim to identify high-risk subgroups. So these findings prompted Danish health authorities to request a review by the European Pharmacovigilance Risk Assessment Committee. So there is also other large study by Harvard, Massachusetts eye and ear cohort study published in JAMA Ophthalmology in 2024. This study observed a significantly higher incidence of NAION among patients prescribed semaglutide compared to those on non-GLP-1 receptor agonist medications. And specifically in patients with type 2 diabetes, the cumulative incidence of NAION over 36 months was 8.9% for the semaglutide group versus 1.8% for the control group. And the hazard ratio was 4.28 with a confidence interval 95%, and a p-value was less than 0.001. This increased risk was also observed in patients who were overweight or obese. And Dr. Brossard, look what's in the news. So there is a lawsuit by a Maryland man who took Ozempic and then became legally blind. He is suing the drugs manufacturer, arguing it had an obligation to warn patients that loss of sight could be a possible side effects. So what do you think?
Yeah, I'm not impressed by the lawsuit. So we flipped a coin, and I thought before flipping the coin, if I am against the association, if I'm for the association between NAION and GLP-1, it's going to be fun because it's going to be challenging. But if I'm against it, it's going to be fun because I'm going to win. Just Bayan went over this, but the GLP-1 receptor agonists, they are licensed to treat type 2 diabetes, and they're also licensed to treat obesity. And they've been found to decrease the incidence of major cardiovascular adverse events like death from a cardiovascular cause, stroke, or myocardial infarction. So that is a huge thing. And again, NAION, it's the most common neuropathy in over 50 that is not glaucoma. But we need to remember it happens 2 to 10 patients every 100,000 patients. So even though when we do neuro-ophthalmology, we feel like this happens all the time, it's not true. It's quite rare. So that's very important to keep in mind when we analyze the studies, right? And if you see the risk factors are for NAION are diabetes, are high blood pressure, hyperlipidemia, obstructive sleep apnea, PD inhibitors. So these patients, the ones that take the GLP-1 receptor agonists, and the patients that get NAION are pretty much the same. They overlap, right? And so again, Bayan went over this, but what they do is they increase your production of insulin, mimicking glucagon. You know, the brand names, Ozempic, Wegovy, Trulicity, Mounjaro, they're out there. They control your diabetes. They help you lose weight significantly. And what is more, they've been proven to offer cardiovascular protection, even to the level of the endothelium, lowering inflammation. So that is very important. Here, the Lancet, they published, so based on several trials, these medications, they demonstrate cardiovascular benefits, and they are a huge tool for these patients since they cause a significant decrease in the rate of stroke, as we said, MI, or death. So this is the big picture. And so let's not forget to see the forest and not just the tree. They're causing like a huge impact in the lives of hundreds of millions of people by now. This is also important. Why are we focusing on these drugs? These are the leading drugs when it comes to expense. So it's been that way in 2023, it's been that way in 2024. So number one is semaglutide, Ozempic, Wegovy, and number two is tirzepatide, which is also known as Mounjaro or Zepbound. So these medications are out there and they're being prescribed every day to thousands of people. And July 2024, Hathaway publishes on JAMA Ophthalmology that there is an association between NAION and the use of semaglutide. So they find, this is a retrospective study, they compared diabetics that were on semaglutide versus the ones that were not on semaglutide, and they saw the incidence of NAION. And they found that overall, just to summarize this for you, in diabetics, so this included about 17,000 patients, of which about 700 were diabetics, close to 1,000 were obese. And they saw that the people that were diabetic, they had a four times more likely to have an NAION than the ones that were not on semaglutide. And among the people that were obese, there was over close to 8 times more chances of getting an NAION compared to the ones that were not on this medication. So this was huge, right? Because we know NAION, we cannot treat it. Once you get it, you get it. And many of the people that get an NAION, they significantly lose part or completely their vision. So it's important in each case, a patient that has NAION, what are you going to say? You're going to say, stop the Ozempic because this is going to happen in the other eye or has a higher chance of happening in the other eye, or keep using it. So this is what happened, right? Lawsuits, patients were suing Novo Nordisk, and these huge companies, and everyone was interested in, okay, is this a final call? Is this real? Is there a real association? So a lot more research and a lot more studies happened after this. What were the limitations of this study? It's a fairly, compared to the studies that we're gonna see next, is a fairly low number of patients, 17,000. It was just one center of patients that were referred to a neuro-ophthalmologist, and they didn't really control for how severe the diabetes was, how obese the patients were. They didn't include the BMI. They didn't include whether they were on insulin, and they didn't consider the A1C. So those are huge things that, were overlooked. So then, just to make it quick for you, I will summarize. Another study published on JAMA, they concluded that, okay, this time they looked, they included huge databases, so it was 37 million patients. This time they say, okay, there is an association, but the risk instead of 4 times is 2 times. And then another one in JAMA March 2025, they say, well, yeah, there is a 2-fold increase in some patients of having an NAION, but it doesn't happen at the 1, 3, 6, or 1 year mark. It only happens after the 2-year mark. Then what happens? They say we need stronger evidence. So there's a meta-analysis. And the group of Silveri, what they conclude is that there is no association. So they went over 69 randomized clinical trials. Of all those clinical trials, they only found 8 cases in the group of patients that were on semaglutide and 4 in the group of patients that were on something else. So the number needed to harm is you need to treat 40,000 patients with these medications to cause 1 extra case of NAION. And every 100,000 patient years, they found that there were 3 episodes of NAION in the group that was treated with other medications and 5.6 in the one that was on this type of GLP-1 medications, inhibitors. Then there's another big study by Klonov in which they include 66 million patients. Initially, they found some increased risk of NAION, but then when they correct for the confounding factors like the diabetes, how obese they are, so on and so forth, no association again. And thirdly, the group of Chow, they did a multinational population-based study. This is the largest study that was done. They basically went over 120 million records, of which they ended up accumulating about 18,000 patients that were diabetic on GLP-1 medication versus other medications, and then 65,000 that were on this for patients that were just obese, and another 65,000 in each arm for patients that were obese and diabetic. And they conclude that there is no association between GLP-1 medications and NAION. So what's the best evidence that we have so far? So a meta-analysis says that there is no association. And what is more, the minimal difference, you would need to treat 40,000 people to get one more case of NAION. Remember that you need way fewer patients to have an impact in stroke or in heart attack or death. And more patients go blind because of diabetic retinopathy than they do because of NAION. So are you going to stop giving them this medication just because of that 1 out of 4,000? I don't think it's very reasonable. So NAION is rare, which makes this kind of study and drawing conclusions very hard. But there's currently no strong evidence to say that you shouldn't keep patients on these medications. They help in many other ways, which are way more relevant than the one extra NAION case that you might eventually get. So basically, don't stop them.
Okay, thank you. With any rebuttals from either of you? Or you go straight to the voting? I think Steve's gonna have that up in a second. Bayan, what do you say about her papers?
So your talk was very great, and you convinced me.
No, truth is, it was.
That's not how we debate, Bayan. We don't do it that way.
Thank you, Bayan.
Okay, Natalie, do you want to give her?
It was that. It's not my credit. It's actually, it was the coin. Yeah.
We might have an easy answer here, it sounds like.
But I agree that maybe more studies are needed just to make sure that it's not associated. It's not due to other confounding factors.
Okay, thank you all. Okay, our final Ross debate for the afternoon is going to have us looking to the east and to the west and have our battle of the throughway. This involves our sister institutions, Buffalo and Syracuse. Dr. Sandra Sieminski serves as Director of Glaucoma Services at the Ross Eye Institute and holds the position of Clinical Vice Chair in the Department of Ophthalmology, the Jacobs School of Medicine and Biomedical Sciences at the University of Buffalo. She is also the Ophthalmology Clerkship Director, playing a pivotal role in medical education. Thank you for that. Dr. Sieminski earned her medical degree from the University of Pittsburgh, go Steelers, completed her ophthalmology residency at Georgetown, and pursued a glaucoma fellowship at New York Eye and Ear. Her clinical expertise encompasses a wide range of glaucoma surgeries, including minimally invasive techniques, as well as cataract surgery. She has a particular interest in exfoliative and traumatic glaucoma, and research focuses on laser therapies and surgical innovations in glaucoma care. She has special interest in international ophthalmology and has completed numerous surgical missions. Dr. Robert Fechtner is chair of the Department of Ophthalmology and Visual Sciences at SUNY Upstate at Syracuse, and he's a distinguished glaucoma specialist with a career spanning clinical care, surgical innovation, and academic leadership. He has authored over 100 scientific publications and served as executive vice president of the World Glaucoma Association. His research focuses on glaucoma pharmacology, diagnostic technologies, and minimally invasive surgical techniques. He received his medical degree from the University of Michigan, go blue, and did his residency in ophthalmology at Albert Einstein College of Medicine. He also completed his research fellowship in glaucoma at Tufts and Montefiore before completing his clinical glaucoma fellowship at UCSD. Beyond his professional achievements, Dr. Fechtner is an avid coffee enthusiast and chamber music performer. Please welcome them both as they present the many sides of interventional glaucoma. I think you're both going back and forth here, so come on up.
So thanks for having me. I'd like to say a special thank you to Dave DiLoretto, who I know very well. He came to Buffalo and helped us out for several years and worked alongside him, the fastest retina specialist I've ever seen work in the clinic. So, and the hardest working. So we wanted to start out together. Rob and I are friends and we really worked together on this. And we wanted to, just food for thought, bring up a patient presentation. So this is actually one of my patients. 65-year-old white male presents for an annual exam. He has a history of glaucoma. He's had cataract surgery. He has good vision, and his pressures are high with a cup to disc ratio 0.6. Looks like he has a little early visual field involvement and some cupping as well as some thinning on his OCT. So I'd like to turn it over to my esteemed opponent, Dr. Fechtner.
Thank you, Sandra. My thanks also, Steve, for putting this together, David, for allowing me to travel west. You all know what you're going to do with this patient. And I know I'm going to lose this debate. I do have some disclosures. None are relevant to my content. So when we talked about this, I've been doing glaucoma since 1944. And I had to reflect, what's changed in my approach to initial glaucoma care over those 30 years? Well, the tanaprost is generic. That changed. Cost my patients $5 out of pocket. And I got a new laser. That might be about it. So is now the time for us to switch to an interventional mindset instead of my generic latanoprost and my new laser? And the first thought I had about interventional glaucoma is non-interventional glaucoma is observation. That means we reject this theory of lowering intraocular pressure. So everything is interventional. However, the current meaning of interventional is procedures earlier in the treatment paradigm, and I attributed this to our neighbor to the north. He goes by one name. He's the most influential ophthalmologist in the world, it turns out. But he hasn't influenced me yet on this. We struggle with evidence-based medicine. I mean, a lot of what we do is how we were trained, what our protocols are, our tradition. But if I'm going to do medicines and laser, is there evidence that medicine prevents glaucoma? Or does topical medication slow progression? Does laser trabeculoplasty lower pressure and maintain pressure lowering? Yes, yes, and yes. The ocular hypertension treatment study asked the question, does lowering pressure delay the onset? We started out treating with timolol. We eventually got latanoprost in the protocol. And this is the standard graph from it showing that almost 10% progressed in observation, less than 5% lowering pressure prevents the onset of glaucoma. The early manifest glaucoma trial, a little bit of a weird study. We couldn't do this in the US because it randomized patients with glaucoma to treatment or observation. I guess this is the non-interventional glaucoma. And the treatment was a little wacky. They did laser trabeculoplasty plus betaxolol, and they added drops if the pressure was greater than 35. I think the most disturbing thing here was 44% progressed with treatment, but 44 progressed in treatment, which is high. 66% progressed without treatment. Lowering pressure slows down progression of glaucoma using drops and laser. Brief history of laser, and I'm doing a sleight of hand here because laser is a procedure, but I'm trying to claim that for my side of the argument because we've been doing laser since 1972. Many of you were doing nothing in 1972 because you weren't here in 1972. Nice study, Gus Gazar did the LIGHT trial where they randomized patients to prostaglandin or laser for initial treatment. Turned out both groups did really well with pressure control at target over 90% in each group, but a little better controlled with laser than with medication. And they have 6-year follow-up data showing that there was less progression actually with the laser than with the medication. So SLT arm did better. Drops arm needed more glaucoma surgery eventually. Isn't it time for laser first? Maybe that's the change for me. Kind of looks interventional, but I'm claiming that in my drops and laser paradigm. With treatments, I want something safe, effective, tolerable, and enduring. Adherence is an issue with drops. Complex dosing is difficult. This is from Alan Robin, though, and they found that people do a pretty good job doing one drop once a day. That sounds like my generic prostaglandin. And patients don't always refill their drops, so we do need to reinforce with them the value of this inconvenient burden to preserve vision. And that's our responsibility. Just to comment, you are looking at the eyes of an ophthalmologist. I knew from the time I was in medical school, his two sons were ophthalmologists, and they gave him every eye drop they had to control his pressure. When he was on drops, he couldn't see because of his ocular surface disease. When he was off drops, he could see, and his pressure was in the 30s. I ended up having to do traditional glaucoma surgery. So there may be some place for an interventional mindset. I like having all the tools, but it's not where I start. So interventional is procedural. Is it time to rethink our approach? What would you do with that early glaucoma patient who needs some pressure lowering?
Well played, well played. So again, I have my title slide up here because I'm starting the bulk of my talk, which is interventional glaucoma, MIGS, and sustained release delivery devices, drug delivery devices. And these are my disclosures. So when I got invited to do a talk like this, I've done a lot of talks, but not a debate before. It was very exciting, and I'm a movie girl. So I thought about this movie. So hopefully we won't battle it out physically like that, but it is one of the essential movie battles. So again, as Dr. Fechtner has alluded to already, the traditional approach for glaucoma has been a stepwise reactive approach. You're getting worse, we add a drop. You're getting worse, we add a drop. Maybe we'll do laser, maybe we'll do a trab after that. But an interventional approach is really an earlier proactive approach. So we're focused on procedural intervention, aim to steadily maintain IOP at target goal, reduce medication burden. And I'm going to talk about that a lot because that's really a big advantage of a lot of these interventions is reducing that medication burden. And what comes with reducing medication burden is we don't have that red-eyed patient who's going into a trab with a lot of injection and a lot of propensity for scarring. So it's tissue sparing and gives us that possibility of doing something in the future for that patient if they need to, because it's a lifelong disease and I'm young, so I'm gonna be following them for a long time. So we talked about laser trabeculoplasty, and so that is part of the interventional glaucoma paradigm, but I'm gonna be focusing on SRDDs and MIGS. So let's talk about the paradigm shift. We've got Rob's diagnosis and treatment plan, which is at diagnosis, we start a drop, we add a drop, get progressing, add a drop, maybe do ALT, SLT, and then we've got trab or tube. And I was going to put someone with red eyes and a seeing eye dog there, but over here we've got starting interventional treatments early can actually give us some lower pressures at the get-go and give us, again, that ability to do a trab or a tube down the road. And this is a really great graph here that actually shows a fast progressing patient and how fast they are approaching that level of visual disability or blindness before death. And intervening early can really flatten that curve and get your patient to their end of their life seeing well. So we'll first talk a little bit about drug delivery systems. A lot of these are in the development stage, and they've been in the development stage for a long time, but we do have two that are available for us. The first one is the intracameral bimatoprost insert, that's Durista, and then the iDose TR, which is travoprost. So what do SRDDs address? Basically, a significant barrier of glaucoma medication is compliance and adherence. Other unintentional non-adherence issues such as dementia, just the dexterity of patients as they grow older, and it really mitigates the side effects of topical medications. So with Durista, which is a 10 microgram bimatoprost implant that was approved in 2020, it lasts 90 days, or at least that's what it's said to do. It's actually lasts a lot longer in some of their studies, and 4,400 times more concentrated at the iris ciliary body level than drops. And there are some side effects, as you would expect. Hyperemia is a big one, and some corneal endothelial cell loss, which increases with multiple implants. So there are two big studies looking at the Durista implant. The Argos looks at the primary endpoint was the proportion of primary eyes to receive no additional meds at 6 months. So after 6 months, 88.6% of primary glaucoma eyes received no additional treatment. And by month 18, very high percentage of patients did not need an additional drop. The Triton is another study that actually looked at the IOP lowering effect after single and as needed implantation for POAG and OHT. So the take home point for this is I initially said 90 days for the treatment effect of Durista to wear off, but this was actually almost a year. And what I'd like to point out here in this slide is not the IOP lowering isn't that impressive, but what I'd like to draw your attention to is at the bottom of the slide, the mean topical IOP lowering medications were far less. And that's one real advantage to these implants is that you're decreasing the amount of topical medications used. The iDose TR is another implantable device that's slow eluting travoprost, and this was approved in 2023. And this is a surgically implanted device that elutes travoprost from 6 to 12 months, and also a very small side effect profile. And there is no significant change in the endothelial cell count in their studies. So in this prospective trial of 133 patients who were on a PGA of any kind beforehand, monotherapy, they were randomized to receive the iDose TR after a washout of their PGA. And the IOP lowering with the implant was superior to the pre-study PGA monotherapy. So this shows the patients at screening with an 18 millimeters of mercury pre-op IOP, and then at baseline after washout. And so the actual travoprost implant offered a lower IOP than previously on monotherapy. So switching gears to MIGS, I know all of you have heard of MIGS ad nauseum, so we don't need to go over the definition here, but essentially this is something that we can offer to patients mainly because it has a very high safety profile, good efficacy, and quick recovery. And a lot of us are used to doing them with cataract surgery, so I'm going to focus on standalone surgeries here. And then there's this other acronym called MIBS. I don't know if you've heard of this, but minimally invasive bleb surgery. This may be ab externo. It causes more than minimal disruption to the normal anatomy, still with good efficacy, high safety profile, and relatively quick recovery. So we may disagree on this, Dr. Fechtner and I, but I do think of Zen and MIBS as something that's not MIGS, and there is a little bit more involved in terms of risk and management in the postoperative period. So what do we have available in the MIGS and MIBS space? And these are all FDA approved. So there's plenty of things you might have heard about that are happening in Europe and so forth. We have trabecular MIGS, which is trabectome, GATT, KDB, Trabex, Scion, and C-Rex. Canal-based is iStent, Hydrus, iTrack, or ABIC, Omni, Streamline, and VIA. Cyclodestructive, we're not going to talk about. Suprachoroidal, you may or may not have heard, there's an AlloFlow Uveo implant, and we'll talk briefly about that. And then the Zen stent. I'd like to point out on this slide that Hydrus is on this slide, but it is not approved for standalone. that may or may not be a multiple choice question in the multiple choice questions that were offered at the beginning of the symposium. So we'll talk a little bit about some of the specific surgeries. Cohook dual blade, which is New World Medical. This is an ab interno MIGS device with a dual blade to perform a smooth incision into the Schlemm's canal. This is a 230 micron foot plate, which lifts and stretches TM to facilitate excision with parallel blades. So just to keep everything straight, this is removing tissue, but we're not doing anything to dilate Schlemm's canal. The iStent has been around for a long time. It's one of the most heavily studied MIGS, and it was approved in 2012 for use in conjunction with cataract surgery. It has evolved over time to go from a snorkel shape to more of a nail head, so to speak, sort of implant. And now iStent Infinite was approved in 2022, and that can be standalone. The Omni surgical system with Sight Sciences is a combination of Trab 360 and Visco 360. This is a microcatheter, which is advanced 180 degrees into Schlemm's canal, dilating Schlemm's canal with viscoelastic. And the goniotomy can then be performed by pulling the catheter centrally and tearing through the TM. Not excising TM, but definitely ripping through TM. And you can also do the canaloplasty. You can do this 180 degrees or 360 degrees, depending on the patient and surgeon preference. GAT is gonioscopy-assisted transluminal trabeculotomy, an ab internal trabeculotomy device, which is essentially creating a 360-degree trabeculotomy without removing the TM. And lastly, AlloFlow Uveo, which is Iontrek. This is the first bio-interventional technology in surgical glaucoma, or BIGS, you may hear along the way. It's the currently only approved technology in the US that enhances uveoscleral outflow. Many of you might have heard of CyPass, which was a uveoscleral outflow device which was pulled off of the market because of endothelial cell loss. This is allogenic scleral tissue implanted into surgically created cyclodialysis cleft. This is very new. They do have standalone data that is unpublished. If anybody wants to speak with me about that after the talk, I'm happy to discuss more. So what is the standalone MIGS efficacy? So there are plenty of studies looking at standalone, and this was a nice review by Nate Radcliffe that actually looked at all of the studies to date and the efficacy. What we may see here is that there's a giant range in mean IOP reductions and mean medication reductions. Why is there a range? Some of that has to do with severity of the patient, presentation, but also surgeons can do 2 clock hours, 3 clock hours, 5 clock hours of a KDB, or do 180 degrees of Omni or 360 degrees. So some of that is just the treatment area. I'll talk about a couple of studies, and my opponent, interestingly, was on this study. So this was before iStent was approved as standalone. This was actually just to look at 2 generation 1 iStents compared to a PGA and newly diagnosed POAG. And what they found that is at 5 years, significantly more PGA eyes required add-on medications. There was comparable IOP lowering, and the significantly more stent eyes achieved treatment success. The Omni has been studied in their own industry-sponsored studies. Romeo did look at standalone data. This is actually a giant population of from the IRIS registry looking at eyes with moderate to severe POAG undergoing standalone Omni over 36 months of follow-up, a minimum of 6 months. So the baseline IOP was significantly reduced at every time point, and the eyes with lower baseline IOP had significant reductions of medications, and the eyes with the higher baseline IOP had significant reductions of IOP through 36 months. And MIGS are safe. So when I'm consenting a patient, particularly for standalone, it's a very easy consenting process because I don't have to worry about a lot of post-operative complications that you would see with a TRAB. The most common complications are transient lymphema, transient IOP spike, and post-op inflammation. And they just don't carry the same risks of hypotony and blood leaks as we would with a TRAB. Looking at the rate of post-op hyphema, and I could do a whole talk on whether or not you need to cancel patients' blood thinners before surgery, it's really not that high. And the highest you can see in this study is with trabectome, and these hyphemas are self-limited. So this is my treatment algorithm. Every surgeon is different, but because for better or for worse, I do them all. Mild at diagnosis for open-angle glaucoma, I think about maybe an eye stent or a limited canaloplasty like the Streamline. Mild to moderate at diagnosis, I think of a goniotomy such as a KDB or a Scion. If there's a patient with moderate to severe glaucoma at diagnosis, I'll think of a canaloplasty and goniotomy procedure together as a standalone or a suprachoroidal stent. But the beauty of this is I still have conjunctiva spared for future treatments if needed, a MIBS or a trab or a tube. And I like to consent patients in that way. I will offer this to you standalone, and if we need to do something more in the future, we can do it. Thank you.
Can you see why I worried about debating Dr. Sieminski? Those were very exciting videos. You just saw an extremely skilled glaucoma surgeon doing them. There is a value proposition with an interventional mindset. And these are some numbers I got mostly from the manufacturers. So you need to know these numbers if you're going to adopt them, and you need to know what the process is for getting paid for them. So for example, on the top, we're looking at the pricing for the Durista. You're not going to do this in your office because you're giving up on the $1,200 facility fee, but you might do it at a slit lamp in your surgery center. There's very little profit for the surgeon for the device because it's priced. So there's very little profit for the surgeon from the device. The iDose, which is a really interesting platform, still very new. After hearing $950,000 for gene therapy and $95,000 for neurotrophic corneas, I'm thinking $14,000 for iDose doesn't look so bad. Some examples of MIGS. Again, there's a facility fee. There is physician reimbursement. I did the standalones. The top is Zen, and it's differential between surgery center and hospital. The bottom is the cost for the Sight Sciences Omni, and I did not have the price. The price is roughly $1,000 for the device. So you need to know the numbers. There is some money involved if you're doing interventional glaucoma. Remember, if you are managing glaucoma medications in the office, that's not a level 3 visit, that's a level 4 visit. Do enough of those and you might make up the difference, maybe not. So these devices are expensive. I'm sorry. These devices are expensive. There is a place for them. Exciting presentation versus stick in the mud. So we know Dr. Sieminski is going to win this debate, but if you're going to start the patient on generic latanoprost, you can vote for me.
So we know these things are expensive. They're not as expensive as Luxturna, but they're expensive. And, I do want to just point out, and we're all aware of this, meds cost money too. In 2017, Medicare spent $1.09 billion on prostaglandin analogs alone. The overall cost to the US healthcare system is attributable directly to glaucoma care is over $9 billion annually. So MIGS and SRDDs can decrease the medication burden and the medication cost. This was also by our god, Ike Ahmed. In Canada, he demonstrated cost savings after iStent, ECP, and trabectome were comparable to monodrug, bidrug, and tridrug therapy at 6 years. So after 6 years of someone being on 3 drugs was 3,168 Canadian dollars, which my kids say is play money, isn't it? And then we have trabectome eye stent, which is the most expensive, is 1,044. So actually, eye stent wins in that scenario. And New Zealand as well. The eye stent with cataract surgery was comparable to the annual cost of most topical therapies after 10 years or less. So we have prostaglandin analogs in the middle there, and they kind of break even around 10 years of a monotherapy with prostaglandins. So that's our debate. I think we went over time, so I don't know if we have any conclusions. All right, thank you so much.
Okay, thank you all. It's tough when they use your own papers against you. That's always, any rebuttals from either of you? It's all been contained? We're good? Okay. Why doesn't all the debaters come up for question and answers? We have about 5 or 10 minutes, I think. Actually, we've got Steve's question here first. So answer your questions, and then as those are being answered, Rachel, Ron, Bayan and Natalie, Rob and Cynthia, coming up.
Keep going.
Yeah.
Can I ask a question, Matt?
Going up.
I have a question, Matt.
Yeah, go ahead.
I've got a great way to settle this debate. Why not just do goniotomy? It costs about, what would you say? Maybe $100 for a heel-on syringe, maybe 25 cents for a needle. It's the same thing as MIGS. We have a 360 procedure, but you can get 120 to 180 degrees with a goniotomy. Takes about, I'd say 30 seconds to do the operation. Wouldn't that solve the problem?
So you like the old procedures better too?
It's interesting, the GAT procedure, which is ripping through 360 degrees, was invented by a glaucoma surgeon who did a keynote lecture at AGS this year. And now he's saying, well, you should you should kind of keep the TM around a little bit because it has inherent pump function. So maybe it's not a great idea to remove all of it. But I think with kids, the pathophys is a little different than adults.
You're opening the pathway, right?
Right,
From the
right.
anterior chamber to Slem's canal.
And we could bend a needle and just do it without the expensive
Right.
device, for sure.
So when I was a glaucoma fellow, we had looked at goniotomy in adult, and it wasn't being done in the US. It had been done in Japan in conjunction with cataract surgery, and the data were poor. So for me, it's interesting that we are now back to looking at goniotomy for adult. I've done pediatric glaucoma my whole career, and goniotomy, if the cornea was clear, was the starting point. Does it work in adults?
Every study that I'm aware of, there has not been many, there's only been a couple, has shown the same efficacy in adults and kids between MIGS and adults. But there's very little data out there because there's less financial incentive, I guess, to do the study. But it certainly works in JOAG, and it's had a big comeback in JOAG. Go ahead,
Right.
Regina.
Regina.
I actually have a question on what is your success rate with all the MIGS devices? Because it looks great.
100%.
100%. Thank you, Dave. Because when we're talking about the cost, maybe it's in my hands, but I usually think that when I put the cost on the MIG, I very rarely take the patients off the drops. So we actually adding it. Just your opinion on that.
I'm just going to comment on the paper I did. That was actually in Albania. That was one of their centers. And there was a lot of pseudoexfoliation glaucoma in that population when I went over there. So I think there are some glaucomas which we identify as being trabecular meshwork dysfunction, pigmentary pseudoexfoliation. It may be different depending on what the underlying mechanism is. I still don't know why pressure is high in open-angle glaucoma.
I think that the first MIGS that I started with was iStent, and nothing against iStent, but I do have some thoughts about the efficacy of the iStent and also leaving something in the eye to wreak havoc, to create PAS, to migrate, to hit the cornea, whatever, that I don't love. I love just the non-implantable MIGs, but most of what we do, I think, is still combined with cataract surgery. So that's a big sort of criticism of the non-MIGs believer. Well, you did the cataract surgery. That's going to bring your eye pressure down, just that alone. Standalone is something that I think I'm becoming increasingly more impressed with. Doing standalone in a patient who's no phakic, like the Albanian study, or pseudophakic. And I think, doing a goniotomy, an extensive goniotomy, can certainly get a combo PGA combo patient off of their combo and down to PGA or nothing. And that's just like a general bird's eye, kind of getting them off of their combo, getting them off of 1 or 2 drops.
Scott, go ahead.
Yeah, to Ron and Rachel, so serum tears versus Oxervate. So 2 questions. One, what's the long-term effect in terms of neurotrophic disease with either of these options? You showed us some information in terms of short-term studies, but what about 2, 3, 5 years down the road? And then the second question is, what about doing dual therapy, using both, particularly in those more difficult patients?
So I think in terms of long-term outcomes, with serum tears, we're a little bit limited with what's in literature in terms of studies that have been done. There haven't been really large trials following patients over time. So I think our experience is a bit more anecdotal or limited to sort of interpreting case series and the like. I think that patients who end up neurotrophic are often complicated and have more than one thing going on with them. Maybe you just have the single HSV patient, and you could maybe target the pathophysiology of that one mechanism. But I find that most of these patients are kind of multifactorial. So my own experience, and Ron, please chime in, is that our treatment is very intensive up front. Once we get that epithelial defect to close, there is some sort of maintenance that has to happen, and they're on drops probably forever, at least in a more reduced form. I have never personally tried, to your second point, Oxervate with the serum tears. I don't know if you've tried that. I can't see why not to try it. I mean, I think in the end, everyone's on some sort of combination therapy, tears, ointment, steroids, serum, there's always more than one modality going on.
I've got a quick question for our neurop colleagues. Does your calculus change with patient before starting treatment with Ozempic has had a bout of NAION? And or if they have a first bout while on Ozempic, what do you counsel the patients?
So I consult the patient that there is no proven association with Ozempic, and just to think about to weigh the benefit versus risk of Ozempic. So GLP-1 agonists in general, a lot of patients get significant benefit in decreasing the level or better control of diabetes, and also sometimes for just weight loss. So I actually counsel them that the risk is very, very low and it's not proven. So that I counsel not to make any changes if they are already on Ozempic, or if they are planning to start Ozempic, that there is no contraindications from our standpoint.
Yeah, so I say the same, that the risk of the other eye being involved is still 15% within 5 years. It wouldn't change it. So I don't ask them to stop.
Great, thanks. I think that's all the time we have before break, where Dave's got a message before we break.
Yeah, quick message. First, I want to recognize our featured lecturers today. Let's give all the lecturers a great hand. But then to recognize Rob and Sandy for their outstanding presence and traveling here to Rochester to celebrate our annual conference. Thank you so much.